Good evening, everyone. Today, this webinar will be conducted and our guest speaker is Dr. Neal Young. He will be speaking to us on Eltrombopag based therapies in severe aplastic anemia. This webinar is brought to you by Mumbai Hematology Group and it is supported by Novartis. It is managed by Mice Ideas. We have discussants with us, Dr. Sandip Shah, Dr. Pankaj Malhotra, Dr. Seema Bhatwadekar, Dr. Rishi Dhawan, Dr. I'm thankful to Mr. Saumil Modi, Rajni Abhijit, and Lekha VK, and the Mr. Rajesh Sharma, Mr. Kalpesh Pangwar, and the team Mice Ideas, Executive Committee of Mumbai Hematology Group, Dr. Neal Young, our international guest speaker, all our discussants who are themselves eminent hematologists and medical oncologists from India, and all of you for sparing your Saturday evening for this very important lecture. I invite you to ask questions, and please do type your questions right from the beginning. We'll try our best to cover all of them. Do fill the feedback form as well, and in turn you will receive your certificate of attendance. For any difficulties in the MHG webinars, you can contact me or Kalpesh, and these are our email IDs. Now coming to the guest speaker this evening, Dr. Neal Young. It's my proud privilege to introduce him. More than introduction, I must mention that he's a great friend of India. He's been visiting India for last 20 years, multiple times, especially Mumbai, and has spoken a number of times in the meetings of Mumbai Hematology Group, Indian Society of Hematology, and guest lectures at almost all premier institutes in India. He has probably seen more of India than probably what you and me might have seen. He is the Chief of Hematology Branch of National Heart, Lung and Blood Institute. He graduated from Harvard College and Johns Hopkins School of Medicine. He did medical residency at the Massachusetts General Hospital and training in hematology at Washington University in St. Louis. Postdoctoral fellowship in biochemistry and molecular institute of health of failure. And today, if we know any failure from its etiology, we owe a lot to Dr. Neal Young. I remember us on anti-thymocyte globulin, and then, of course, right up to now, Eltrombopag. His interests are also in the normal and abnormal hematopoiesis, viral infections of marrow cells, and parvovirus has been his great interest. Autoimmunity, mechanisms of genomic instability, and leukemogenesis. His work includes clinical trials in his bone marrow failure clinic in Bethesda, stem cell stimulation with TPO-RA, that is Eltrombopag, immunosuppression, and telomere modulation. Basic science in virology, immunology, cell biology, especially parvovirus B19, telomerase gene mutations, immune pathogenesis of marrow failure, and epidemiology, the largest population-based study of aplastic anemia, which he did in Thailand. It's published over 400 original research articles, more than 150 reviews and chapters, and 10 monographs. His lab has trained dozens of world leaders in hematology all around the world. He has been a dear friend of India, as I mentioned earlier, visiting us regularly for almost about half a dozen times during last 10 years itself, and educating both senior consultants and our fellows and trainees with updated research in the field of aplastic anemia and allied subjects. So now I invite severe aplastic anemia. Thank you so much to allow me to speak to you. Dr. Young, please.
Yes. Please put your slide, sir.
Can you see that?
Not yet, sir.
Well, let me thank Dr. Agarwal for a very gracious introduction and to express my gratitude for this invitation, your fortitude to be watching this so late in the evening on a Saturday, and my regret also at not being in person in India, not so much to see the sites, but to see so many valued colleagues and dear friends there. I provided an excuse to Dr. Agarwal that unfortunately I'm suffering a bout of quite severe back pain. The pain is not under control. So if you see me wincing during the question and answer period, it's not because of your questions, but because I'm in some physical discomfort. What I'm going to try to do in the next 45 or 50 minutes, the time that Dr. Agarwal allotted to me, is in the middle of my talk to focus on the practicalities of Eltrombopag therapy as a new addition to the treatment of bone marrow failure. But I want to begin with a brief introduction as to current concepts, my current concepts of aplastic anemia, and to finish also briefly with just a glimpse at the laboratory work that is really altering our view of the bone marrow, both the normal and the abnormal bone marrow. I won't walk you through complex genomic slides, but I want to give the audience a sense of the excitement of this field in the laboratory. Now, I do hope you can see my first slide.
Yes.
Oh, good. Okay. There's always a great rush of adrenaline to make sure that your slides are actually being shown, and then a sense of relief that they're actually there. So can you see the first slide?
Yes.
Wonderful. Okay. So let's get started. Aplastic anemia is an old disease that's attracted a lot of famous people, well-known names like Paul Ehrlich and Professor Vaquet, very important figures in the United States relating to laboratory medicine and benzene. It's been around a long time, which has allowed confusion to develop over the diagnosis. And I want to clarify some of that confusion, which is really the result of inability to study this complicated disease due to what seemed to be a diversity of etiologies, lots of things that were associated with aplastic anemia, from drugs and chemicals to hepatitis and pregnancy. Most of the time, we never knew what might have precipitated this disease. And of course, it's very hard to study because there aren't a lot of cells, and historically, the patients didn't survive very long. So this has been a really difficult problem for those interested in both the clinical and laboratory aspects of aplastic anemia. Now, I had the opportunity a couple of years ago to kind of summarize several decades, more decades than I want to admit, of research in aplastic anemia. And I provided in the New England Journal what I hoped was a simplifying but also educational approach to this disease that's based on a separation between the pathology, which is what you see in the center, the so-called empty bone marrow, and what I consider the three major pathophysiologies that allow arrival at this similar, identical pathology, the bone marrow filled with fat. I'm only going to emphasize one today, which is what I think we should be calling immune aplastic anemia. But I want to mention that on the one hand, there is bone marrow damage. That's by far the most common way of reaching this pathology. That's what we do in the oncology clinic with radiation, what can occur with poisons in the environment. And I think we should think of that as physical and chemical damage. And on the other extreme are constitutional forms of marrow failure that are dictated by, in general, inherited or lifelong defects in hematopoiesis, but also in the immune system. Now, these relate obviously to one another. There are instances of overlap, but I think they really are distinct, deserve different ways of study, and also, of course, require different treatments. I think thinking about this pathology as being unifying, a simple way of perhaps a simple analogy is that a very prominently red skin or chronic diarrhea are all clinical manifestations, but they can reflect many different pathophysiologies, from sun exposure to an erythema that might be an inherited syndrome of the skin, to specific diseases that result in a similar appearance. The marrow injury is relatively simple. Something physical, something chemical, leads to usually either immediately fatal, as for example in excessive radiation exposure, but generally reversible marrow deficiency that is dose related and can generally be inferred from a history of exposure. The constitutional defects similarly can be recognized usually in a pediatric population, usually but not always with a family history, and most important that there may be other organs involved that are obvious and physical anomalies, and that these, as I'll tell you in a moment, are rare as an acute presentation of severe pancytopenia. Now, as hematologists, you should be aware of the constitutional aplastic anemia predisposition, myeloid neoplasm predisposition syndromes, because they can present in adulthood, although not commonly. The ones that I would really emphasize would be the telomeropathies, especially the genes TERT and TERK, because they lead to a less severe manifestations than, for example, DKC1, or the rare telomere genes that affect the telomere shelterin complex. But GATA2, RUNX1, these are definitely mutations that can present in adulthood with either myelodysplasia or occasionally aplastic anemia. In our laboratory, we are undertaking a fairly massive comparison between these constitutional and immune types of aplastic anemia. And as I think you can appreciate, based on clinical manifestations, it is actually not that difficult to separate the inherited forms of marrow failure with clear genetic defects that can be identified by genomic screening from acquired bone marrow failure. And acquired bone marrow failure, especially in its severe form, is very rarely associated with a genomic abnormality. We're using machine learning as well as these large numbers of patients to make this distinction, and I hope that will be published to the benefit of practicing hematologists soon. But what I'm going to discuss today is immune aplastic anemia, which is a disease. And I think it really should be thought of as a disease of the immune system in combination with hematopoiesis, where hematopoietic stem and progenitor cells are the targets of this aberrant immune response. And also immune aplastic anemia, which I've highlighted here. This is from my New England Journal review. We can now think of as being not a unique or odd rare hematologic syndrome, but that's one that's related and can give us lessons to other immune-mediated marrow and also peripheral blood failure syndromes, especially myelodysplastic syndrome, paroxysmal nocturnal hemoglobinuria in adulthood, as well as single lineage marrow problems. This is a speculative slide. The actual size of these circles is based on PubMed citations, not on true epidemiology, but it's meant to emphasize that we can have full pancytopenia, but also single lineage failure, and that T cells or B cells may dominate, as far as we know, in these pathologic immune responses. You, more perhaps than we in the West, are familiar with the dreadful natural history of aplastic anemia, that patients who present with severe blood count abnormalities have a very poor prognosis without treatment. And even with blood transfusion and androgens, historically, at least in the West, the likelihood of being alive a year after diagnosis is on the order of 10 or 20%. So this is really a dreadful disease, and I won't show the slide, but it's also a disease that predominantly affects young individuals, making it even more tragic and more challenging in practice. I've shown this slide many times, and I show it in India partly to acknowledge my AIMS colleagues for their splendid epidemiologic work. Known for many, many years, this review of mine from Asia, have shown that the disease really is 2 to 3-fold, maybe even more in certain areas, 2 or 3 times more common in Asia than it is in the West, meaning mainly Europe and what little we know in the United States. And in this wonderful presentation from AIMS, that it's a disease that can rival in the outpatient department as well as in the hospital the frequency and challenge of adult acute myeloid leukemia. And as was mentioned by Dr. Agarwal in the introduction, we do have a very well-performed study from colleagues in Thailand in collaboration with many other institutions that have defined this increased rate of aplastic anemia, although the reasons for this increased rate in Asia, including in India, remain obscure. This slide is new because we've received funding just in the last year from the Department of Defense in the United States to undertake a very large GWAS study of aplastic anemia, both in Asia and in the West. You can see the list of colleagues that we've enlisted to donate DNA from their patients. So the hope is that over the course of the next several years, and I would really hope Rishi knows our interest, that we really would be able to enlist data from India to complete this study. But the hope is to come to some conclusions as to inherited risk factors related to the proclivity for aplastic anemia in India as well as in other parts of Asia. We have the money, we need to get the samples. Now, that aplastic anemia is an immunological disease, really the most striking data have come from the clinic, and they're pretty old at this point. These are very early studies published in the 1970s by colleagues in Europe, especially, that efficacy, surprisingly, of anti-lymphocytes in the setting of transplant that on occasion would lead to what appeared to be spontaneous recovery of autologous hematopoiesis. Sporadic results have been studied in all parts of the world with the observation that anti-thymocycline used in combination in general with cyclosporin immunologic responses in about 2/3 of patients and clearly improves survival. So without transplant, but just with immunosuppressive therapy, many patients do have hematologic recovery and survival. So that's one very important, perhaps the most important evidence that this is. A second important evidence from the clinic withdrawn. Those of you who treat anemia are aware of the dependence, especially of the platelet count, and continued cyclosporin, often at low doses, and with withdrawal, the fall in blood counts. This is from one of our papers. Taper or simply stop cyclosporin will continue to require cyclosporin, and that's that T cells, which cyclosporin inhibits, the function of that T cells are in this disease. We know that survival of ATG and with cyclosporin to levels that are quite acceptable, 80 to 90% 5-year survivals in these patients. So hematologic response is associated with better outcomes for the patients. It's not simply a laboratory observation. We're not entirely sure how ATG and cyclosporin work, but in this work that was published a few years ago in the New England Journal, it was clear that ATGs are not equivalent, that rabbit ATG, despite being more depleting, did not result in comparable outcomes, the most likely explanation being preservation of T regulatory cells, shown here in the patients with horse ATG treated in blue. And the problem with rabbit ATG is that it depletes not only total CD4 cells, but also this T regulatory component, which we think is important. I'd like to mention more recent data, again from the clinic, indicating the importance of T cells, which has emerged from the use of checkpoint inhibitor therapy and aplastic anemia, as well as these other diseases that I showed you in that speculative Venn diagram, also are a not uncommon complication in patients in whom T cell activation is utilized to treat cancer. This is from a summary of the World Health Organization database. Similar work looking at PD-1, anti-PD-1 inhibition. Again, these syndromes in which T cells, immune system, can on occasion lead to severe or to peripheral blood destruction. There are also now observations that carding of non-Hodgkin's lymphoma can also have fatal complication, the development of bone marrow suppression. Very strong evidence from clinical observations, research by practitioners, that T cells can eradicate the bone marrow stem and progenitor cells and lead to marrow failure. We have animal models. I don't want to emphasize this in a talk that's mainly clinical. Many of you have seen these lovely three-dimensional visions of the views of the bone marrow of mice that are given T cells that are dispirited in either major H2 or minor histocompatibility antigens, very efficient at eradicating, replacing the bone marrow of the mouse with fat, invasion shown here in these aqua colors of T cells. And we can work out the plausibility of a lot of the mechanisms by which lymphocytes can very specifically damage, in fact, kill bone marrow stem cell and progenitor cells. Again, not to dwell on it, but this is just one recent example in which we were able to demonstrate that not only is gamma interferon a major player in these mouse experiments, but so is tumor necrosis factor, but not by the same mechanism. Gamma interferon acting more directly and tumor necrosis factor acting indirectly, probably by promoting gamma interferon production. The major point being that even in well-constrained and controlled experiments, the immune system, the interactions among immune cells are very different. This is also an experiment that I'm going to refer to later to test therapies in the mouse model. And although both cyclosporin, which we use in the clinic, and rapamycin or sirolimus, which is only now being introduced for the treatment of aplastic anemia, have very different effects, even again in these highly controlled experiments. And I'll just indicate that rapamycin, much more than cyclosporin, increases T regulatory cells, and rapamycin, much more than cyclosporin, deletes, because of its mechanism of action, rather than simply suppresses cytotoxic lymphocytes, and has very different effects on the cytokines that are produced. I want you to just remember this slide because I'm going to refer to it when we talk about ongoing clinical studies. And from human data, this is old work, but we can measure oligoclonal T cell families, especially CD8 effector cells. These are just the various V beta defined cytotoxic lymphocytes. It's in one typical expansion of V beta 3. Other cytotoxic lymphocyte expanded. You treat the patient, the clones are reduced, or in fact, the patient remits, and you see the recurrence now, as well as new T cell clones, phenomena of epitopes spreading, new antigens being expressed in the damaged organ. And now we can look in a very sophisticated way. This is more recent work, looking actually at the antigen binding regions of these oligoclones that are present. You can see a nice example here, these oligoclones that are present in patients with aplastic anemia. And because I mentioned that regulatory T cells are quite important in aplastic anemia, as well as in other autoimmune diseases, you see this deficiency that we reported over a decade ago in T regulatory cells in patients with aplastic anemia. Much more sophisticated ways of now looking at T regulatory subsets, but basically showing the same information that T regs, especially subsets of T regulatory cells, probably have a pathophysiologic role in allowing this aberrant T cell response. And finally, that among the hematopoietic cells, we can appreciate, for example, with cells that have lost the ability to be recognized by cytotoxic lymphocytes through class 1 due to either loss of heterozygosity on chromosome 6, RMP, or actual mutations, we can appreciate that these are relatively common, indicating that there are escape phenomena that occur in the hematopoietic target cells. All right, that's the background that I wanted to provide. All of this background should make the empiric observation that all of this laboratory experimentation. So I'm just showing you many studies that have been published have found that 60% or so evidence from the laboratory-based observations, replacing horse with rabbit ATG, replacing ATG with cyclophosphamide, adding drugs like mycophenolate or sirolimus or growth factors have just not improved on ATG, horse ATG plus cyclosporin. And this seemed to be a barrier. That was the presumption, was that the limit to non-transplant therapy was the paucity or complete absence of hematopoietic stem cells in those patients with the most severe forms of aplastic anemia. This deficiency in hematopoietic cells is evident when we look at the bone marrow aspirate, when we look at the biopsy, again with confocal microscopy, we just don't see CD34 cells, or with flow cytometry, the familiar observation that there just are not sufficient CD34 cells reflecting hematopoietic stem and progenitor cells in patients with severe aplastic anemia. And that the failure or likelihood of response was likely due to numbers of stem cells that we were not able to measure. They're just below our limits with studies that we can do in the laboratory like CD34. Now, the purpose of this talk is really to emphasize a very surprising observation that has turned out to be remarkably useful in patients with marrow failure. And we're really in the middle of studies investigating thrombopoietin mimetics. So to refresh your memory, Eltrombopag is one of several TPO mimetics that were developed because it was impossible to deliver thrombopoietin as a molecule in the same way that erythropoietin could be delivered as a molecule due to its immunogenicity. And multiple drug companies, including Novartis and others, really took the very difficult task of developing TPO mimetics based not even on fragments of the thrombopoietin molecule, but on synthetic derivatives that had the same binding properties as TPO, but could be delivered orally and were clearly not immunogenic. And this is the Eltrombopag's molecular structure. This is not a peptide. This is a synthetic mimetic molecule that mimics a TPO's activity. Now, many individuals are interested in testing, and of course, TPO mimetics were shown to be effective in ITP, especially refractory ITP, immune thrombocytopenic purpura, and were in wide use. And my colleagues and I actually undertook a study that was not actually designed to show that TPO mimetics would be effective in aplastic anemia. In fact, we were dubious that Eltrombopag or thrombopoietin, if it could be administered, would be effective because in general, thrombopoietin is one of a number of growth factors that are very highly expressed and abundant in the blood of patients with marrow failure. Giving G-CSF, giving erythropoietin is just not effective in aplastic anemia. And as a sort of public service to avoid patients being subjected to unnecessary treatment, patients in my clinic who were refractory to immunosuppression were given short exposures to a molecule that we believed would be non-toxic, easy to deliver, but also not likely to be effective. And we were very surprised, astonished, in fact, that in our initial studies, we saw a relatively high response rate, between 40 and 50% of patients who showed improvement in blood counts. That was in itself surprising. But these blood count improvements were more than in platelets. They included especially hemoglobins, sometimes very striking improvements in hemoglobin on the order of 4 grams per deciliter and improved in patients, as well as good improvements in platelets and white cells, and that these responses were durable. So surprising that patients responded at all, tri-lineage responses, and robust, durable response. Highlighted in red that we also saw an undesirable side effect, which is clonal evolution. I'm going to return to that, but I want to emphasize it. And this single center study led to approval by the American Food and Drug Administration for Eltrombopag for patients with refractory aplastic anemia. I want to reiterate that this was a monotherapy. This is a single center, single drug study of Eltrombopag. So there was no confounding by other drug treatments. Now, it of course doesn't make much sense to wait until patients become refractory, undergo several different courses of immunosuppression, which has been conventional, develop transfusional hemosiderosis, are susceptible to infections, become alloimmunized with platelets, and so on, the problems with chronic aplastic anemia. And it made sense, it was rational, to combine immunosuppression against the immune system, which we knew was effective, and the addition of a growth factor working on the stem cells themselves to shift this histogram towards more stem cells in the bone marrow, and therefore a higher probability of recovery with non-replacement transplant, a non-replacement or transplant therapy. So these are the results that again were published in the New England Journal of the initial cohorts, a total of about 90 patients with some modifications as to how the patients were administered Eltrombopag, 3 months versus 6 months, time of ATG versus a small delay. Overall, the results were comparable, with an overall response rate at 3 months between 77 and 87%, 80% overall, clearly higher than the 60 to 65% proportion than the usual 10 or 15% of complete that we see with immunosuppression alone, now on the order of 30%, as high as 50% or so in those patients with maximal cyclosporin exposure at 3 months, and then again at 6 months. So these results were strikingly better than immunosuppression alone. Again, all patients received standard horse ATG and cyclosporin. The research was the addition of Eltrombopag. Adverse events were rather minimal. The most common would be liver function abnormalities, generally not severe, generally resolved spontaneously. Most patients could resume Eltrombopag after a short period of a drug being held. The most serious acute problem was this very striking cutaneous eruption. This occurred in just a few patients, but for those of you who give Eltrombopag, you should be aware that this is a very pronounced erythema, and it will recur with reinitiation of Eltrombopag. So occurrence of a rash like this, obviously other drug eruptions need to be excluded, infections need to be excluded, but Eltrombopag should be stopped and not re-administered. However, this is an unusual complication. Now, these are new data. They've not been published, but we've continued to treat patients. So the original 90 almost doubled. So these are new data that I'm presenting to you here. This is a summary of the clinical information in these patients. The most obvious is that there's been no great difference in the proportions of patients with very severe aplastic anemia, and we've used the same drug regimen, which is the full 6 months beginning on the first day of ATG in these patients in the extension study. The table here shows you that the time to follow-up is somewhat shorter because, of course, we have patients who are continuing to be enrolled in the study. Overall, I can indicate that the response rates have held steady at about 84% at 6 months, with again about 40% of patients achieving complete responses. So in general, this extension study has continued to confirm the original work that was published a few years ago in the New England Journal. But all the data I'm going to show you subsequently concerning relapse and concerning clonal evolution includes this larger data set of almost 200 patients. Now, one very important observation, which I want to credit to my close colleague Bhavisha Patel, who has done the later analyses of the extension cohort plus the original cohort, deal with the late complications in aplastic anemia. So Bhavisha has looked at the time of relapse and made the very important observation that relapse is occurring at two distinct time points, both consistent with the immune mechanism underlying aplastic anemia. Most relapses are occurring here at the 6-month time period when Eltrombopag stopped in all patients. But cyclosporin 5 milligrams per kilogram. And you can see the relapses that have occurred counts. Most occur at this point in which cyclosporin boost. The second time of relapse is discontinued per protocol at 2 years. More relapses are occurring here early than occur here at 2 years. And I'm going to show you in a minute why that discrepancy is practically important. We originally thought that we could use the relapses that occur when patients had 2 years to test a prevention sirolimus. Now, rapamycin or sirolimus transplant, because it's an effective transplant setting for graft versus host disease, and our colleagues at NIH, is thought to be tolerizing, not kill cells. It simply represses their activity. Sirolimus is a metabolic agent that cells. So the idea potentially have a renewal of their initial T cell attack in the absence of cyclosporin, addition of a drug that recognizes and kills active T cells might be effective. So this study is ongoing. It's designed to accrue about 110 patients. We're about 2/3 into the accrual process. As you can see, Bhavisha was kind enough to update this slide for me. And at least at this point, we have a hint. This has not been subjected to a statistic, obviously, because the study is too long, is too early. But you can see that we have about 20 patients who have finished the 2-year time point, and a fair number of patients that we can evaluate at 3 months. We have half of the relapses, no deaths, and fewer transfusions in those patients who do, in fact, receive a brief course of low-dose sirolimus at this 2-year time point. Now, I told you when I was describing the previous slide that most relapses are not occurring at 2 years. So in retrospect, we're kind of unhappy that we did not introduce this treatment at 6 months. But for purposes of our protocol, this was simply not possible. But I'm really hoping that in the future, we will be able to organize a multi-center trial to introduce sirolimus at this early stage when we think it's most likely that T cell activity is being, that T cells are again being re-stimulated, that we're rebooting the immune process in an attempt to really reduce and in fact eliminate the likelihood of relapse. So relapse is, of course, a problem, but relapse is manageable. And a much bigger issue, much greater challenge in the clinic, but a great opportunity in the patient population is the development of a myeloid neoplasm late in the course of aplastic anemia. These are historic data published some years ago that indicate about 15% of patients who undergo immunosuppression, these are our NIH data, will develop MDS. That's usually manifested as a cytogenetic abnormality, almost always aneuploidy. I'll get into detail in a moment. The relationship between aplastic anemia and paroxysmal nocturnal hemoglobinuria and leukemia has been recognized for over 50 years. This famous editorial by Dr. Damashek, my own attempts in the last several years to explain clonality, including this recent paper that I recommend to you in Blood from 2017. I want to be clear because I think there is confusion, some of it unintentional, some of it purposeful, as to clonality. Clonality is poorly defined in the setting of aplastic anemia. Sophisticated hematologists, that's probably most of the audience that I'm speaking to, understand that clones are not clones. There are P&H clones, which generally are not fatal. That's clonal disease. It's probably in response to the immune environment, but it is in general. So yes, it's true that more than half of patients with aplastic anemia have P&H clones. That is not the same thing as having a monosomy 7 clone. 6p loss of heterozygosity is also clonality, but it's a reflection in perhaps 15 to 20% of patients of escape from immune attack. And that is also not the same as aneuploidy. So the clonality that we're talking about is clonal cytogenetic abnormalities, especially chromosome 7 abnormalities or complex cytogenetic abnormalities which carry such a poor prognosis. This is for clarity. So clonal evolution in patients who are treated on our protocol is not different from the clonality that occurs with immunosuppression alone. So while there is concern, and I want to stress there is concern with treating patients who have refractory disease, who have been subjected to multiple rounds of immunosuppression or treated late, that Eltrombopag is important in that setting. We do not have evidence to this point that clonal cytogenetic abnormalities are increased by de novo treatment when immunosuppression and Eltrombopag are combined. Now, in detail, the survival of patients obviously can be affected by a number of phenomena. This is the overall survival, all of our patients to date treated with immunosuppression plus Eltrombopag. This is pretty good. When we look at survival by response, not responding, mainly because patients can go on to other therapies, is not as good as when patients respond, but it's not terrible also. At 5 years, about 80%. We do not so far see a difference between partial and complete responses as they affect survival. Now, why does thrombopoietin even act in patients with aplastic anemia? I mentioned to you early on that we were dubious that there would be any efficacy for topomimetic because patients have very high levels of thrombopoietin. So why should giving more of a mimetic work? This is still quite mysterious. But my colleague, Andre Rochelle in his laboratory, a variety of experiments that Eltrombopag experiment, which is a xenograft model in human CD34 cells are infused into an immunodeficient mouse, and the output from these cells can then be measured as human CD34 cells. When cells are stimulated by thrombopoietin, you get nice recovery of human cells. But if the thrombopoietin is combined with interferon before the cells are infused into the animal, there's no recovery. Eltrombopag with or without gamma interferon allows recovery of human cells. So this is a very, I think, convincing demonstration that in the specific setting of gamma interferon and presumably other lymphocyte cytokines, Eltrombopag is able to evade a blockade in growth factor signaling. We know also that thrombopoietin does not work simply on megakaryocytes. The molecule's receptor is expressed on hematopoietic cells and early progenitors. TPO can lead to this increase in hematopoietic cells in vitro. Knockouts, as well as humans with defects in the TPO nipple, not only have simply thrombocytopenia, but is shown in this patient who is heterozygous for MIPL, the receptor gene, that the bone marrow is quite hypocellular. So thrombopoietin does work on hematopoietic stem cells, not just on megakaryocytes. Now, a phenomena that I think is quite important is that thrombopoietin, in contrast to erythropoietin and Neupogen, GCSF, does not return to normal in patients who respond to immunosuppression. This is actually in some respects a surprise, but easily explained. These are our own data. Others have reported similar information. When patients' neutrophils and red cells come back to normal, their levels of TPO and their levels of erythropoietin also return to normal. You can see that here. But here are various patients who have responded with complete recovery, and yet their thrombopoietin levels remain above normal. Now, why is this? It's because thrombopoietin regulation is not sensitive to the platelet count alone, but to megakaryocytes as well. And patients can have good, complete responses, a platelet count of 100,000, or partial responses of platelet counts of 60,000. But as many of you are familiar, when you do the bone marrow, megakaryocytes are still deficient. Those platelets are being produced by limited numbers of megakaryocytes. And this sustained production of TPO may not be beneficial to the patients long-term because of thrombopoietin's continued stimulation of hematopoietic stem cells. So what are some of the implications for future therapy? Well, we hope that earlier introduction of effective therapy, not months or years after the patient has responded, may help preserve stem cells and avoid their destruction. I'll show you a protocol we're doing for that purpose. When ATG is not available or tolerated, we hope that cyclosporin and Eltrombopag may in fact be adequate, perhaps in combination with sirolimus. And of course, the platform that good blood count recovery gives us allows the opportunity to experiment with immunomodulation, as I've shown you with rapamycin. And then there is experience, some of it just recently published, that Eltrombopag in other settings, moderate aplastic anemia, low-risk MDS, we've just published this paper in Hematologica, as well as single lineage failure and other bone marrow failure syndromes, may be effective as well. We know that in moderate aplastic anemia, monotherapy with Eltrombopag alone is effective in about 50% of patients. That work is under review. But the combination of Novartis's Promacta with horse ATG and cyclosporin is now an approved regimen for the treatment of patients with severe aplastic anemia. There is competition. I want to go through this very quickly before finishing. In the New England Journal paper, I took some effort to summarize the data for transplant. We're not going to go through this slide. The information is available. Transplant, of course, is the preferred therapy, always in younger patients. But I want to stress that transplant is not a panacea. It's not 100% effective. This is from Andrea Bacigalupo's paper in 2015. I don't think the data have changed. If you look at those patients who undergo conventional bone marrow transplant, this was not the aim of this paper. It's always worthwhile looking at the controls. You can see that while the results are excellent, they're not perfect. Patients still have gross disease. There's still a significant under the best of circumstances. We can select those patients who are well based on whether they get bone marrow, peripheral blood, their age, and so on. But again, it's not 100% recovery. Here's a paper that just appeared online. I found it quite interesting. It's from colleagues in Switzerland, in which the comparison is of long-term outcomes. We're talking about decades, 20 to 30 years, with transplant and with immunosuppression. And you can see that these are not different out at 20 or 30 years. They're also not so great. So we have a lot of room to improve on both ATG and immunosuppression. But what's especially interesting in the patients who have immunosuppression is this convergence on full recovery. That's what's shown in green. You see that early. In transplant, of course, you've replaced the bone marrow, but of course you also have this earlier death due to transplant complications. But 20 or 30 years down the line, the patients who have done well with immunosuppression have done well with immunosuppression with good counts. Haploidentical transplant was also summarized in the New England Journal paper. We're all enthusiastic about this because it greatly expands the donor pool. But the results that have been achieved with single center studies in the United States and in China, where HLA is much different in terms of its sharing in populations, may not be transferable in practice. This is a paper that's just appeared in Experience. Again, it's not to say that haploidentical transplant effective. We send our own patients to it. Delayed recovery, graft versus host disease, both chronic and acute, occurring even with post-transplant cyclophosphamide, and survival that is probably not different from immunosuppression. And even in China, where there's much greater HLA sharing, haploidentical transplant is very popular. This paper, also in the BMT journal, 6% of patients who undergo a transplant there have poor overall survival, mainly due to cardiac toxicity. from the regimen. So again, not to discourage, but only to be realistic about the role of haploidentical transplant. So this is a summary. I think I've said everything I want to say, but this is the major point, is that we want to get patients to their definitive therapy as quickly as possible, within the first 3 or 4 months. This is Bhavish's newest protocols in which we are initiating therapy with oral drugs at low risk on diagnosis. This includes patients, for example, who are not able to reach the NIH for visa or logistical reasons, may be stuck in Jamaica or in Latin America for a couple of months before they're able to come. Get them started as soon as possible on cyclosporin and Eltrombopag. Telemedicine with a once-a-week interview with the patients, obviously careful follow-up with the laboratory, mainly to see that this is feasible, that we can treat this severe disease at a distance, and of course we'll also get information as to how many patients have improved even partially by the time they reach NIH. And of course we're interested in expanding this effective therapy to similar diseases that we think share the same underlying pathophysiology. This is our simplified strategy. Again, it's in the New England Journal for those who want to see it in detail. Now I want to finish with talking a bit about clonal evolution. This is the big problem. I showed a slide earlier. Sorry. Why is this occurring? It's not due to the mutations. This is work we published a few years ago. There are mutations in patients with aplastic anemia in the myeloid neoplasm gene. They are not particularly predictive of those patients who go on to a poor outcome. Bad mutations definitely are associated with overall survival, but you can see that those patients who progress, there's not a big difference here, even though it is statistically significant. So we think that the acquisition of harmful mutations can lead to MDS and AML, but most frequently does not. These mutations can be stable. In contrast, multiple of our studies have shown that those patients who have telomere attrition, short telomeres, that remains the best predictor of those patients who go on to aneuploid abnormalities. This may be a cause and effect. It may be that the aneuploidy is a result of short telomeres. It may only be a reflection of the fact that very few stem cells are functioning in those patients most at risk, leading to telomere attrition. In patients with refractory aplastic anemia, this is not a good slide to look at. I'm just going to show you tell you the result. Patients with refractory to disease who are at risk for the development of aneuploidy and MDS, this does not correlate with the presence or with the growth of somatically mutated clones. This occurs, I think Eltrombopag is eliciting abnormal clones present in the bone marrow, but it does not appear to be by mechanism of Suman. I want to just return also to show you clonal abnormalities. That's shown here. The rate is actually remarkably low. These are patients with monosomy 7, frank MDS, and with complex cytogenetics. So if we can keep that rate at 3 or 4 years at 5%, we'll have done quite well. And the low-risk patients seem to be at very low risk. Those patients with these types of clonal cytogenetic abnormalities do not progress. They don't have blood count changes, and they often lose these abnormalities over time. These are the high-risk patients, and you can see that they mainly have cytogenetics. Some have MDS, but a large proportion of them do not have large somatically mutated clones or clones at all. And this evolution has not in a major way affected the outcome of patients, mainly because they can go on to transplant later or to other therapies. And the last thing I want to say about treatment is that disappointingly, Eltrombopag combined with immunosuppression has not helped our pediatric patients. There's not been an improvement in response rates and probably no significant improvement apart from better support moving to transplant of Eltrombopag. So these data need to be reproduced that is most effective for those adult patients. Okay, I want to stop here because I've run a bit long. I'll skip not critical slides, mainly to thank Emma Agarwal, who's also referred patients know Olga Rios, my right wonderful laboratory group who do the work that I wasn't able to present to you today. So I'm going to finish. I hope you don't know when you give these talks whether anybody is actually hearing you. You're only talking to your screen in your basement. I put on a tie to sit, in my relaxation room. But I hope everybody heard. I hope everybody could follow watching me in pajamas. I do have pants on. I have fully changed in case the screen slipped. Questions. Thank you again, Dr. Agarwal, Rishi, for inviting me to give this lecture.
Thank you so much, sir, for this wonderful talk. You can take it for granted that everybody was glued to this, listening to you. Nobody has fallen asleep and nobody has moved.
Okay, but you are allowed to be in pajamas.
Also, thank you to call us sophisticated hematologists, and I hope we are. And I must say that the type of work which you have done in last 4 decades, I don't think that I have the power, but I should recommend you for the Nobel Prize.
Thank you very much, but I don't think that's going to happen. My son is going to win it instead.
Oh, the genes percolate down, yes. So this was something great which we heard. It has changed the treatment of aplastic anemia totally, including in the third world like my country. People have been using now Eltrombopag, and courtesy Novartis, we have patient assistance programs, so patients are able to afford it. And yes, there is reasonable experience from this side as well. So we have 3 types of questions for you. First of all, I have my faculty here from India who are present directly with you. Then there are questions which are out.
Okay.
Here I will just tell them to get ready with their. I'll ask Dr. Radhika to keep her question ready. Eltrombopag dose, whether there is something, no response, whether it can keep going up, whether Eltrombopag should be started right from the beginning, and those patients who don't have adequate response, whether Eltrombopag can be continued for a longer period.
Yes, those are excellent questions, and most of them not able to answer. So let me answer the question that I think is easiest. We do not have good evidence from our monotherapy studies that increasing the however, prolongate, and we certainly have seen in patients who better when beyond 6 months. So I think that is open patients, for example, in India, who may be seeing some evidence of improvement at the 6-month period. It would certainly be rational to continue the Eltrombopag for a longer period of time. The third thing I would say is that we do start Eltrombopag immediately. We don't see much problem with liver function abnormalities. That was the biggest worry, is that the combination of the potentially combined ATG, cyclosporin, and Eltrombopag would be quite manageable, and generally quite manageable. I think that there are very limited data, important one, there's limited data on the pharmacopag in the South, in the subcontinent. Most of the data have come from East Asia and have recommended a reduction in the dose. And I'm not aware, perhaps you do know, whether the Indian population is going to be more sensitive in terms of their response. I think pharma to determine.
Right, sir. So Dr. Radhika is Associate Professor, Department of Clinical Hematology at Nizam Institute of Medical Sciences, Hyderabad. Radhika, your question, please.
Thank you, sir. Thank you, Dr. Neal Young, sir. It was a great presentation. My question is, what is the role of serial bone marrow evaluations at 3 months, 6 months, and yearly thereafter in the setting of stable counts and no dysplastic findings for early detection of clonal evolution? Do you recommend it?
Yeah, that's a really good question. And I'm things that are very sensitive to abnormalities. I think it's a very reasonable question. Blood counts, will you take them to transplant at that point? Would you replace another therapy? I think not. So I think that this frequency of bone marrows is probably not necessary in the conventional setting.
Yes, sir.
Thank you, sir. I will request Dr. Damodar Das to keep his question ready, and I will read out a question that has come from the Eltrombopag for severe responding when you are doing the both, or you will do molecular studies by.
Yes, we only look at karyotype. Now we also follow. To be clear, the patients who enter our study will have a genomic screen for an inherited abnormality, just to be clear on that. And our patients will be assessed at the 6-month point in peripheral blood for somatic mutations. But this is for research purposes because we really don't know the significance of somatic mutations. We do not do a mutation panel on bone marrow, nor do we do FISH. We're not convinced that FISH is that much more sensitive, especially in a hypocellular bone marrow, than conventional cytogenetics. Returning to the somatic mutation point, our New England Journal paper, I'm afraid, was very commonly misunderstood to indicate that, for example, the presence of an ASXL1 clone predicted myelodysplastic syndrome. We were not able to show, even in our very large patient cohort, that any single somatic mutation we don't feel it's legitimate to look at a patient's peripheral blood even at 6 months, see a 10% clone and say, oh my goodness, we have to go to a bone marrow transplant. And our experience in multiple patients is that 10% or 20% ASXL1 clone can come and go. We can see the patient, they're doing great 5 years later, and they still got that same ASXL1 clone. So I think its predictive value is limited, if any.
He also wants to know whether you do baseline karyotyping and whether the marrow samples are adequate to obtain some fruitful results.
Yeah, we do karyotyping. They often are not adequate. So that's correct. And when we don't have an adequate specimen, we will make the assumption it's normal, mainly because the therapy we offer we think is modest. And if we're wrong, and this is one of the things I think we'll learn now treating patients at a distance, if we make a mistake and a patient in fact does have monosomy 7, the options are not great. And if we have to go to a transplant at that point, not much is lost by a month or 2 months of cyclosporin and Eltrombopag. That's part of what we're trying to learn. So I think that even in the setting where we're not able to obtain an adequate bone marrow for conventional cytogenetics, but the bone marrow is extremely hypocellular, as all of you know, if that is leukemia, it's extremely difficult to treat. Virtually impossible to treat a patient who has no bone marrow reserve and is highly cytopenic with chemotherapy.
Right, sir. Dr. Damodar Das,
Yes, sir.
Professor, Department of Clinical Hematology at Guwahati Medical College and Hospital. Dr. Damodar, your question, please.
Yes, sir. Good evening, sir. Sir, we have a patient whom we treated 1.5 years back with ATG plus Eltrombopag. He was fine for 1.5 years. And initially also we are unable to do cytogenetics, and now also recently presented with encytopenia. We are unable to do cytogenetics. And 2 days back he presented to us with 70% blast in the peripheral blood. So my question is that what are the predicting factor response to ATG? And second question is that when we are unable to do cytogenetics, in that case, what should we do? And third question is that in this case, this patient transformed into acute leukemia, what should be the management?
Yeah, so that's a very interesting question. And Bhavisha also has written up 4 of our patients, this is out of several hundred, and including patients, by the way, beforehand, who developed really classic MDS AML very late, very disappointingly so. You know, you're at the 5-year point, the patient has done fine. Sometimes the blood counts are okay, and then you do the bone marrow and you see blasts. It can occur. And in that setting, which is a minority of patients, I think somatic mutations do play a role. So these patients often have, we have 4 patients total, but they may have cytogenetically normal acute leukemia, but have mutations. Curiously, in one of these patients, we recommended them to go off to a bone marrow transplant. He was a young man in his 40s. He was not enthusiastic about transplant. When we called to see how he was doing, he was still in a complete response. His bone marrow blasts had decreased. So it's a very strange phenomena that can occur. But in the assumption that when you have blasts in the bone marrow and hypocellularity, we have to call that leukemia, and I would go to a transplant. I don't think there's another option.
Thank you, sir. I request Dr. Suman to this question ready. And there's a question from Dr. Abdullah. Do you see thrombosis and marrow fibrosis when you use Eltrombopag for aplastic anemia?
No and no.
Okay.
So, it's easy. We've never seen thrombosis, partly because our patients do not achieve these blood. They can get platelet counts of 200,000, but they don't go to 500,000. Also, per protocol, when a platelet count passes 100,000, we will reduce or eliminate the Eltrombopag. We've also looked very carefully for fibrosis. We've not seen that occur in any of our patients. So I don't think that those are risks in this patient population.
Right, sir. Dr. Suman Pramanik is clinical hematologist at Ahmedabad Hospital, RNR Delhi. Dr. Suman, your question.
Good evening to you, sir. Sir, am I audible, sir?
Yes.
Yes.
Sir, the question which I want to ask you is that we have a patient of A megakaryocytic thrombocytopenia. Sir, have you got any experience on treating these patients with Eltrombopag?
No, we don't. I've only heard anecdotally that some patients respond, some don't. I think it's reasonable. We don't, as you know, it's a very rare diagnosis.
Yes.
So there's really no possibility of studying it in a research setting. I don't think I can give you advice one way or the other. I don't think it would be harmful. So I think it's not unreasonable. I would certainly check for MIPL mutations. Those are, we find, not an infrequent, and as you know, there are RUNX1, MIPL. These are constitutional problems that can occur in adulthood. Is your patient an adult?
Yeah, adult patient, 36-year-old lady, sir.
Yeah,
So
I think it is looking for these germline mutations. We have been surprised. The use of Eltrombopag is not unreasonable. It would be valuable.
Keep your question ready. And we have a question from Dr. Sen Win. In aplastic anemia, is it essential to start Eltrombopag early, or can we wait to see the failure of ATG plus cyclosporine?
I can't answer whether it's essential. We don't really know, but certainly I appreciate the cost issues. I'm aware of that, but I think it's desirable on principle, and at least our studies suggest that early treatment is better. And as I've emphasized, because of the success of alternative donor transplants, even in adults, my view is that we should move to the best therapy, determine whether that's effective. If it's not, that's indicated. I'm less and less sort of stepwise increase in treatments because I think it puts the patient at a disadvantage.
Thank you, sir. Dr. Rishi Dhawan is Associate Professor, Department of Hematology at AIIMS Delhi. Rishi, your question. Rishi, you are muted.
I wanted to ask, how do you choose which myelodysplastic syndrome patients you offer treatment with immunosuppressive therapy in your practice? And in that subset of patients, do you consider doing a
we always do next generation sequencing. It does not put up, you've got a 30% P53 mutations that are associated with leukemia. We rarely see that. So we're using, very conventional criteria for low risk MDS. And as you know, there was a recent compilation of all the data using ATG cyclosporin alone. It came with leadership from Yale, looking at a consortium of MDS centers in which on the order of 50% of patients with low risk MDS responded to immunosuppression. Those are the patients that we will treat also with the combination. Now, of course, it's very difficult. Let me make it clear. If we see a patient with 5 or 7% blasts, we consider that high risk and will not treat that patient with Eltrombopag. If we see a combination, multiple large clones with that are high risk for progression, we will not treat that patient with either immunosuppression or Eltrombopag. We're quite convinced that immunosuppression is effective in the low risk setting, perhaps even more so in patients with hypoplastic MDS, where there's a presumed immune component that's reducing the bone marrow cellularity. So those are the patients we favor. In the paper that will be published shortly in the British Journal by Bhavisha, we report a couple of dozen patients, 50% response rate. But I want to be clear that these are odd patients. Several of them evolved from aplastic anemia to cytogenetic abnormalities. They'd responded, evolved, they respond to Eltrombopag. Others have hypoplastic MDS. We do not have a large experience, mainly due to the complexities of referral.
Yes.
There are a lot of studies out there now for patients with MDS, so everybody's in competition for those low-risk MDS. But there is certainly a subset of patients who can respond quite well. Excellent subject for study, by the way, in India, if you can collect the patient.
The challenge what we face is that, we don't have, I don't think many of the centers have access to good cytogenetics. Doing cytogenetics by conventional karyotyping in a hypocellular marrow is another challenge. Unless there is a clue with regards to, combination of hypocellular marrow with non-erythroid lineage, morphological dysplasia, then maybe consider those. And in those patients, we are sending next generation sequencing. However, we are not getting anywhere with formulating a strategy. Is flow cytometry for LGL clone helpful in this case?
We do it in all patients. We rarely see it in patients with pancytopenia. LGL, we have protocols in LGL, but it is usually neutropenia plus anemia. We do LGL by flow cytometry as well as molecular studies. I don't find it a major problem in the differential diagnosis of the classic patient. I think this is I think one approach that might be considered. You are in a developing country. There, as has been pointed out by MDS experts, low risk MDS is not so low risk. Patients do not have normal lifespans. They die usually of cytopenias. From my point of view, you'd obviously have to go through other experts and your own institutional review boards. If you can't get conventional cytogenetics because it's either not affordable or the bone marrow is a hypocytor, I think it's reasonable to come up with a clinical diagnosis. You can look at a bone marrow. If there are no blasts, you can make other assessments in terms of whether you believe MDS is present, and that's your case definition. And if you're giving a treatment that you think is low risk, as for example, a combination of cyclosporin and Eltrombopag, that's ethical in your setting and potentially a benefit to your patients. I don't want to make what is a complex conversation overly simplified, But we've had this discussion in person at other meetings that Dr. Agarwal has organized, and I think it's wise to learn from others in different circumstances, but you have to find your own way that you as a community feel is legitimate, and there's not some ethical standard that's written in stone that you have to treat patients in a particular way, especially when it's not possible to do it. It's great to recommend to a patient, why don't you go off and, have all these studies done, which are going to bankrupt you, your family, and are not feasible because you're not going to be able to get on an airplane in the middle of an epidemic. So your ethics are determined by what is best for your patients in all balances.
So another comment I had, so one of our DM students, he's doing a dissertation on looking at the response rates of adding Eltrombopag to and comparing it, the combination of the standard ATCAM by Pfizer versus the generic Bharat Serum ATG. So there is a generic ATG which is available in India.
Yeah.
Professor Pankaj will have more inputs on its availability. But so we are comparing it, and what we have around 35 to 40 patients who have got it. What we are seeing is that by virtue of the logistics and the accessibility of our patients getting funding for immunosuppressive therapy, there is a reasonable gap between diagnosis and them getting ATG. The median of 4 to 60, the range is from 4 to 60 months. And however, even in that, when we have added Eltrombopag, around 40 to 50% of patients have had a response rate, overall response rate. So
this is to the Indian formulation or to the?
No, this is overall. We have not analyzed the data for different subsets of ATG.
Numbers are small, obviously. Yeah.
The student had sent me an Excel sheet, and I was going through it when you were giving your talk. So the range is from 4 to 60 months. And of all the patients who have been evaluable for response, the response rate is at 50%.
Yeah. That's pretty good given the delay. I think this is, several points that I would make. One is that the Bhavishya's protocol in which we institute cyclosporin and Eltrombopag on the first suspicion of aplastic anemia. For example, a hypocellular aspirate by a hematologist in the community. That's what we're getting at. We're trying to, the analogy is with APL. That, you see a patient with acute promyelocytic leukemia in the emergency room, you're not waiting for molecular studies. You have urgent care. If you're wrong, you're not going to harm the patient with ATRA, right? You are treating with what you think is life-saving, and you're willing to make a mistake. And I think that thing delay, if Eltrombopag is, given for that purpose, that's one. The second is, which I think you could gain with the addition of Eltrombopag ATG. So it's entirely possible the Indian formulation of ATG will improve results. That would be very important.
We will come back to you.
Yeah.
Lots of questions pouring in. So, sir, there is an entirely different subject I want to take you to. Dr. Amit Khurana. Seeing this patients now, and the bone marrow is sick. We treat them the similar with water has been there out.
These are the patients who were hematologically normal before COVID-19.
Beg your pardon, sir?
These are patients who were hematologically normal before they developed COVID. I have not heard of that, Professor Agarwal. I don't know that. So you're informing me, and if you're seeing that, that's really what the best approach is.
Best seeing frequently hemolytic anemia and aplastic anemia. You can type Dr. Pramanik. But the outcome at 2-3 months, the patients have almost about
without treatment, without any specific treatment. I mean, there is this very interesting phenomena of this hyperimmunity that may be part of the problem of especially older patients. Interesting work in why young kids don't have such a big problem. Maybe they don't kick in their adaptive immune response. They rely on innate immunity. We can do a lot of hand waving and speculation, but I would guess it's part of this exaggerated immune response, and whatever the mechanism that leads to T cell recognition, I'm happy that it's going away on its own, but very interesting from a pathophysiologic point of view. Absolutely worth, I would really recommend you writing up the patients. If you can do it nationally.
Right. Request Dr. Seema, chemotherapy-induced myelosuppression.
Yes, I don't know the answer to that because I'm not privy to the data. All the companies that are studying romoplastum and studying Eltrombopag, I don't know anything more than you know by the results. My own guess is that it would be somewhat limited because patients will recover within a few weeks in most instances of chemotherapy. Repeated cycles, prolonged cytopenias, I don't know. I just have to tell you I don't know.
Dr. Seema Bhatwadekar is Director, Department of Hemato-Oncology and Bone Marrow Transplant at Sterling Cancer Center, Hilal Amin General Hospital, Hematology Oncology Care Center at Vadodara. Seema, your question.
First of all, thank you, Dr. Young, for giving such a illustrative, nice lecture, nice talk, in spite of having aches and pains, the enthusiasm you are having. And every time I listen to your aplastic anemia lecture, we always learn something or other. So thank you very much. And I would like to know, sir, that in this age put in an Eltrombopag, you have shown that there is can we have predictors who will pack and cyclophosphamide in this patient, one, and second, you Eltrombopag in such patient safely.
Yeah. Now these are important and yet not answered questions. I think Bhavisha will eventually be able to determine whether there are predictors. I don't have those numbers now to tell you. And unfortunately, we've seen patients who were in complete response, really normal or virtually normal counts, who have relapsed. Now, how long can we continue cyclosporin? The disappointing aspect of that very important curve that Bhavisha generated is that we had hoped that simply reducing the dose of cyclosporin to a manageable 1.5 milligrams per kilogram would be adequate because there's much information that's so, but in fact, most of our relapses are occurring at that point. Now, maybe that's contributed to by the Eltrombopag also being discontinued. I just don't know. I'm obviously not happy, as none of us are, with the idea of continuing full dose cyclosporin indefinitely. That's just not going to be good for patients' kidneys, and you should be monitoring. So I think this is an unanswered question, more reason than ever to try to come up with a relapse prevention protocol that would allow us to get to a better dose or really to finish with cyclosporin indefinitely. We do have patients who are on Eltrombopag for very long periods of time. So I think that if they experience with the refractory patients, which is so important, is that almost all evolution occurs quickly. For those patients on our refractory protocol who are just receiving Eltrombopag, in 3 months if they have monosomy 7. You don't have to wait years. So you could make the argument that if you've got a patient on Eltrombopag and you want to reduce the cyclosporin, just keep them on the Eltrombopag, because if they're okay at 6 months, they're probably going to be okay. But I don't think we have clear answers to these questions at this point, and it's really unfortunate for the patients. I will mention that in Europe, the habit is often to continue patients on cyclosporin indefinitely, and then to very slowly try to taper. There's nothing irrational about that. So I think if you're in practice and you're dealing with a patient and you want to reduce the cyclosporin dose by, let's say, 10%, every several months, that's perfectly reasonable. We don't do it because it's not our protocol. But last thing I was aplastic anemia for a long time, and I thought I could tell what a relapse was. With Eltrombopag, it's a little trickier. And I'll give you the obvious example. We'll have a patient either at the 6-month or 2-year time period who stops cyclosporin, stops the Eltrombopag. Their platelet count is 130,000. And we'll watch over the course of the next several months, and the platelet count will drop to 70,000. The other counts are fine. Is that a relapse? That's a rhetorical.
It is partial, yes.
Or is it just resetting the thermostat? And in the sirolimus study, we've waited because, again, patients are often starting with good blood counts. And what we commonly see is first, the relapse is only in the platelets. The other counts are fine. And that it also appears that the new platelet count is perfectly sustainable. So a patient who has 100,000 platelets, we stop everything, and their platelet count falls, only the platelets, to 50 or 60,000. But I don't know whether that's a relapse. It's hard for me to say now the patient should go back to cyclosporin indefinitely, or we should retreat with ATG. So I think this partly has to do with the biology, which I didn't have a chance to talk about, of whether the platelet count is really the same as a red cell count, or really the same as a neutrophil count. I think not. I think it's reflecting something different about stem cells, but that's another conversation. But it's the sort of thing that you have to really look at the individual patient and try to figure out at this point.
Thank you, Seema. Dr. Pankaj will be asking his next question. Meanwhile, Dr. Deepak Bansal wants to know, sir, you said that the pediatric group does not benefit from Eltrombopag. Is there a cutoff age?
Yeah, the cutoff age that we use is 18, and we don't see any particular difference between older children versus younger children. It really seems to apply to all children.
There's a similar question. Do you have clear-cut guidelines? Whom will you give immunotherapy plus Eltrombopag, and whom will you send for transplant directly?
Yeah, so again, we're restrained by our protocol criteria. It's more complicated probably than is necessary, but we generally will not see a patient who is eligible for a conventional transplant and can afford it. Now that's a little complicated, but it means that, for example, if we have a patient who is impoverished, we have the system in the US that is not entirely fair. We have a patient who cannot afford a transplant and is determined not to pursue transplant, we can treat that patient. Now, if the patient doesn't do well, we can transplant them. But in general, we will not treat a child who has an HLA-matched sibling. We will treat a child whose parents have decided they want to wait on a well-matched MUD, but will indicate that, if we don't see a response in 3 or 6 months, you should go to the MUD. And of course, our patients are fully counseled. Adults, it's more complicated because there are 30-year-olds who don't want to take a chance even on an HLA-matched sibling transplant. But again, the idea is to get them to transplant quickly. So if they don't respond to immunosuppression, they should be transplanted within 6 months. And 6 months seems to be the rough cutoff for when you increase the risk of a transplant. And of course, there are many patients can be treated with immunosuppression and do perfectly well if they have to be transplanted afterwards. But in general, we will send a patient, advise a patient to go to transplant when that is the conventionally correct thing to do.
So there's a related question by Anand Prakash. He wants to know, why is Eltrombopag not effective in children?
Not affecting?
In children, in pediatric patients, what is the reason?
That's a really good question, and we don't know the answer. It's not due to a difference in pharmacokinetics. So the children achieve similar blood levels to adults. So everything beyond that is speculation. One possibility is that children actually have an adequate stem cell reserve, and that giving Eltrombopag doesn't do anything to improve that. But that's completely speculative. I really do not know. I really do not know.
So Dr. Pankaj Malhotra is our very senior friend and colleague. He's professor in charge of clinical hematology, Department of Internal Medicine at PGI Chandigarh.
Yeah, thank you, sir. And it's always a pleasure listening to Dr. Young. And we have listened to you so many times, but I would reiterate what Dr. Seema had said. We always learn something new, whether it is history or pathophysiology or treatment. So very nice.
You're a very tough audience. I always have to come up with something new because you actually remember what I said the last time.
Okay, so I have a couple of questions, and I might have asked you these questions sometimes, but maybe there is some new development. So one is the looking at the epidemiology of aplastic anemia. Whether the prevalence of aplastic anemia is related to the economic development of a country. So what does these epidemiological studies in Asia shows? Whether for example, Singapore, where in the last 2 or 3 decades it has become a developed country. So whether the aplastic anemia incidence has gone down, or what is it in the world?
Yeah, I don't have definitive evidence because, of course, it's hard to repeat these studies. My impression is that it does go down with development, and that's based on my conversations with my Thai colleagues, who, of course, ran the study in Thailand. We were only consultants, and their impression is that there's less aplastic anemia now. I think that that's also the impression in Japan, that there's less aplastic anemia now than historically. For example, when I wrote that paper with Japanese, Chinese, and Thai colleagues so many decades ago. So I think that is likely. There's also this general suspicion, but very hard to prove, that aplastic anemia is more prevalent among the lower economic strata. Now, it's hard to tell, right? Because there's just a lot of poor people in developing countries. So there are a lot of people who can develop aplastic anemia. I can't give you any specific data, but that is my impression. So there's hope that economic development will in fact improve.
Thank you. And my second question is, one of the major problems which we face in the clinic is by looking at the patient, whether it is immune-mediated aplastic anemia or toxic or toxin-related aplastic anemia. So as with many other autoimmune disorders like SLE, you have a simple blood test to diagnose. So is there any work in progress, which we can just do a simple test and say, it is immune-mediated aplastic anemia and not toxic?
No, the answer is no. I have certain biases, and these are biases that come from my own practice. I think that we see very few patients in which I'm convinced that there's a toxin involved. Now, this is heavily influenced in the United States by the legal world, because there's really an industry in this country that any particular exposure, no matter how many decades ago and no matter how low, may have damaged the bone marrow. And because I also think that medical drugs were overestimated historically. There's a bias that is generated by the fact that you publish one paper and then another paper and so on, that is not held up very well when formal studies have been done. And I think that the third is that we develop drugs that are meant to damage the bone marrow. It's what we give, prior to a transplant and when we are treating patients for cancer. And yet most patients will have autologous recovery. It's really hard to eliminate all those bone marrow cells. So to have drugs to have either chemicals or medicines that were not designed for that purpose be so efficient at eliminating the bone marrow directly has always seemed to me to be somewhat suspect. Now, can certain drugs act through an immune mechanism? Yes, I think that that's a real possibility, and there are a lot of different ways you can formulate that, but in the end, you've ended up with immune aplastic anemia, and you have to treat it as such. But those are prejudices. They're not really well formulated. The only study, and we probably have talked about this before, It's not a great study. The Europeans, again, Bacigalupo, some years ago made a comparison of all the patients that they had seen. This is hundreds and hundreds of patients, and the assumed etiology. So these are the patients who come to European centers, and the physicians say, well, this might be benzene, or this might be a thyrostatic, or patients just saying, this is idiopathic. So he compared these two groups, same ages, same sex distribution, same responses to immune, express the patients with idiopathic or now what we would call, but it didn't suggest that, for example, people who were in the workforce or had particular occupations were really different.
Thank you, and wish you a early recovery from your back pain.
Thank you, good to see you again.
Thank you, Pankaj. Sandip, be ready with your question. And meanwhile, there is a question from Indonesia. Dr. Robinson wants to know, if there is a response in the peripheral blood, should you still do a bone marrow biopsy to evaluate the response?
Yeah, that's a good question, and the answer is probably it's not necessary. If you are treating a patient, again, finances, patient wish, you're treating a typical patient with aplastic anemia whose blood counts are improving or go to normal, you know, the bone marrow is really, I think, for research purposes at that point. With the exception of Eltrombopag, there, you know, obviously if you picked up a cytogenetic abnormality, you might want to monitor that patient better. But it is, we often do see patients, less so with Eltrombopag, but you often see patients, as you do, who have improvement, and the bone marrow still doesn't look very good. It's still hypocytor, but the counts are great. So how does that help you? It's really not very useful information. But I would again indicate that with Eltrombopag, because of this worry of early transformation, I think with Eltrombopag, one early bone marrow is worthwhile, just because it would lead you to monitor the patient more closely.
Thank you, sir. Dr. Sandip Shah is consultant hemato-oncologist in charge of BMT Department of Medical Oncology at GCRI Ahmedabad. So Sandip, please.
Again, thanks for a great talk, Dr. Young. And most of my questions are of whether positive PNH clone may response to Eltrombopag.
Not that we've seen.
And my second question is that there's an anecdotal paper, a combination of cyclosporine and levamisole, giving 100% response rate. So
from China.
Yeah.
From China.
And yeah. Levamisole is a very easily available drug in India. So what is your opinion?
I mean, we've had this discussion before. It's very difficult to evaluate these studies. I mean, virtually nobody gets 100% recovery with aplastic anemia. With the best drugs that we have, I don't know what the action would be of levamisole. So I want to be tactful. I want to say that someone should look at it systematically and see whether it's true or not. But I can't comment more than that. There are some strange things that are done in different parts of the world, and it's hard to evaluate them. Not in India, but elsewhere.
Thank you.
Yeah. So I'll ask Dr. Radhika to keep the next question ready. And meanwhile, Dr. Mukul Agarwal wants to know whether romiplastim is a substitute for Eltrombopag.
Yes, I don't have the answer, but there are, I don't have the answer based on my own data, but there have been papers presented both orally and I think some published now that do indicate romiplastim is effective. So despite differences in the binding site, there's not, I think, a real reason to believe that romiplastim would be less effective. And there is published data that, I think it's from Korea, that it was quite effective in the setting of refractory disease. So I would suspect that it's equivalent, but there's not a lot of information.
Right, sir. Dr. Radhika, you have a question?
Yes, sir.
Go ahead.
Sir, most of the aplastic anemia talks are always focused around management of severe aplastic anemias. So I would like to know, what is your therapeutic approach for transfusion-independent non-severe aplastic anemia and transfusion-dependent non-severe aplastic anemia?
Yeah. So there really is no standard of care for moderate aplastic anemia, is there? Or for patients who seem to be doing okay despite having very low blood counts. So again, I'm a bad person to ask this question of because we do studies and we've had only limited experience with moderate aplastic anemia. And moderate is a huge range, as you know. I mean, you can have a patient that's clearly hypocellular, it's got a platelet count of 60 or 70, a hemoglobin of 10, they're doing fine, they've got good neutrophil. Do they need to be treated at all? So I think the answer is pretty individual, and there are not a lot of great studies. So let me make a couple of comments. One is that I think most important in a patient with moderate aplastic anemia is to determine whether this is constitutional. As I showed in one of my early slides, I don't worry very much about the patient who is coming in with terribly low normal blood counts in the past. That is virtually never constitutional. Much more typical presentation, minimum do telomere length and to do chromosome fragility, and if you can, to do a genomic scan. Because those patients, that's not a surprise if you find RUNX1, GATA2, and that's important to know because of the likelihood of development of leukemia and for family studies. So that's really important diagnostically in the moderate patients. If you've eliminated that, then I think it's very dependent on the blood counts and to some extent on the patient choice. If a patient is close to severe aplastic anemia, you can treat them as such. If they just narrowly miss a platelet cutoff of 20,000 with 25,000 and have 550 neutrophils, I would treat that patient off protocol as severe. Now the patient who's in between, who's sitting with a platelet count that can impact on their life, a young person with a platelet count of 30,000 who can't do sports, I think that those patients can be treated with immunosuppression plus or minus Eltrombopag, partly to see whether there's a response. And that's low risk, and it gives you information, and it may improve the patient. But I think it really depends on the level of the blood counts. Patients whose blood counts are low and have hypocellular bone marrows, but are fully functional, you can watch and wait. I don't think you gain, no evidence you gain anything at that point.
If the patient has a HLA matched sibling?
I would not transplant a patient with moderate aplastic anemia. Most physicians, I think, would be reluctant. I think age is less of an issue. So sometimes there's this, I think almost it's foolish anxiety. I'm 35 years old. I should get my transplant now because I'm going to be much worse off when I'm 40. I don't think we have to believe that. If a patient is worried, they've got a transplant option, tell them to keep their sibling healthy and just see what happens. Because many moderate aplastic anemia patients do well indefinitely. I'd say half, they stay the same. So why go through the risks of a transplant?
Symptomatic moderate aplastic anemia with a HLA matched sibling, sir. Symptomatic moderate sibling.
Again, I think most transplant physicians are not enthusiastic about it. Again, it depends on what makes it moderate. As you a platelet count of 10,000, still moderate? Yes, I would agree. A patient is being transfused, but they're hypocellular bone marrow? Yes, that's a patient you could consider transplant.
Thank you, sir.
Thank you, Dr. Radhika. Dr. Damodar, if you have a question, keep ready. And Dr. Akanksha Garg from Ahmedabad wants to know, in the COVID era, she has a boy who is 10-year-old, aplastic anemia. There is no matched sibling donor. Should she treat with ACE therapy, Eltrombopag and immunosuppression, or go for a MUD or haplotransplant?
Yeah, I mean, it's hard in both cases, right? I mean, you've got the virus around you, you don't know whether infection is going to be good or bad. And also, I would assume that like here in the US, there's a concern about hospitalization. So I don't think I have a clear answer. If there's not an HLA matched donor, I probably would immunosuppress first because I think you can minimize the time in the hospital. I don't think the immunosuppression would affect susceptibility or outcome, especially in a 10-year-old, as we talked about earlier. So that would probably be my preference based just on the information that you provided. and with the understanding that a mud transplant can be done later, but it is going to be a while before there's repletion of the immune system in the setting of a transplant, even a well-matched mud. Part of it would also depend on the neutrophil count. So if you have to get those neutrophils up quickly, you might want to, the patient can tolerate a month or two of waiting on immunosuppression, that would be okay.
Yes,
Thank you, sir. Dr. Damodar, do you have a
Sir, before
Yes,
starting ATG therapy, is there any predicting factor that lead us to respond to ATG?
No, we don't actually have one at this point. And part of it is that when we did the analysis for the New England Journal with Eltrombopag, there was no predictor for response, but partly because almost all patients did respond. For long-term outcome, as I said, short telomeres seem to be predictive of a poor outcome. But we have looked repeatedly because PNH has been described as and we don't see a relationship with the presence of a PNH clone or not. So I wish I could say that there was something that would tell us whether a patient's likely to respond, but there isn't in our hand.
And second question is, sir, when we are unable to do cytogenetics because of no mitotic cells, in that case, what should we do, sir?
We call it a blank result, and we deal with it as aplastic anemia.
If the NGS can help us?
So we've never found fish for MDS in that setting to be helpful because in general, when there are not enough cells, there are not enough cells for anything. And again, I don't know what you make of a 1%, 2%. I mean, the values are, the fish is good when you've got hundreds of cells to look at, to quantitate, but if you're worried about, a very small clone, I don't know what that means. If you get a 4% monosomy 7 just above the cutoff, I don't know that that would discourage me. I mean, I think, this is a bigger story, but I think all our bone marrows are really abnormal. I want encouragement from all of you. I'm writing a review of the functional significance of somatic mutations in disease, and the usual picture, because every cell has got lots of mutants. It's really amazing. The newest genomic studies, I know I've got a TP53 bone marrow. So picking up low numbers of genes, because they're there and we live long lives without having this bad stuff happen to us.
Thank you, sir.
Dr. Damodar. Dr. Suman, you can plan your question. Meanwhile, Dr. Nikhil has 2 questions. He wants to know, where is the place of danazol therapy now?
Yeah, so we're continuing to study danazol. I think danazol is a very good treatment for patients with telomere disease. We know that from our own studies. There's a replication study, I'm happy to say, that's in press in the British Journal. It may be out. It was a European study that also saw a high rate of response and telomere elongation. I don't know that there's much role for danazol outside of constitutional marrow failure. Of course, there's a large experience in Fanconi anemia for improvement in blood count. In acquired aplastic anemia, but the data so far are not supportive of that.
The dose of Eltrombopag should be like...
should have a pretty large collective experience of doses. So I would say that I would depend on you. If you're not running into problems using the full dose, I'd say that your patients probably behave like European and American patients. But as I said, I think pharmacokinetics are a better way to do it. Now you can do dose escalation in patients. So you could start low if you're apprehensive and build up the dose. But I'm not sure what you would expect to see. Liver function abnormalities, presumably.
And here's a third question. Can he replace sirolimus right in the beginning, cyclosporin replacement with sirolimus right in the beginning?
Oh, that's an interesting question. That's a really great question. I think the answer might be yes, but I would be worried because we know cyclosporin works. So as always, you are replacing something that you know is effective, and I don't think ethically we could justify that. I think the sort of study that I would want to do would be, let's say all our patients respond by 3 months. That at that point you could stop the Eltrombopag, continue the cyclosporin until 6 months, and then replace the cyclosporin with Eltrombopag with sirolimus for a period of time. But I would be apprehensive and I would worry ethically about not treating a patient with cyclosporin when it's so well established. But if the question is, would it make sense to do that? Yeah, it probably would make sense to do that. But I think of the period of relapse or relapse's potential as being like what we can do in an animal study. You can cure an animal of anything. I mean, you can cure leukemia in animals really easily when there are only 4 leukemic cells. And we can cure aplastic anemia in our animal models very easily. We give ATG right away, no problem. But we don't have that opportunity in patients with aplastic anemia. They already come in and they're sick. So we have to do what we can when they're sick. But when they relapse, they're more like the beginning. It's like rebooting the disease. So that's why I'm choosing that point of relapse as being, this is a little bit like an animal study. We can kind of believe that the immune system is getting revved up again to do what it did when this patient got sick in the first place.
Thank you, sir. Dr. Suman, you have a question?
Sandip, my question would be, is the effect of Eltrombopag, is it same the de novo patient and in the relapsed patient, or there are some differences in the responses and the behavior of the patients to Eltrombopag therapy?
Yeah, so I don't have a formal answer to that very good question because no one has published the efficacy of Eltrombopag alone in relapsed severe aplastic anemia. But 2 things to say. One is that in the initial study of monotherapy, when patients have relapsed, coming off Eltrombopag, they responded. Months or years later, the counts fall. Well, that's unusual, but they Eltrombopag. So if you're patients in the study that I described at length, when we stopped cyclosporin and Eltrombopag, most patients respond to cyclosporin alone, but some do require the addition of Eltrombopag. But I cannot comment on whether Eltrombopag alone would be effective in that setting. So in monotherapy, refractory patients, you can restart them in Eltrombopag and they have a high chance of responding.
So Dr. Rishi, you can think of a question. Meanwhile, Dr. Vrinda wants to know, so are there a group of patients who should be treated with ATG and cyclosporin alone, and another group where Eltrombopag should be added, or all the patients should get triple therapy?
Yes, because we don't have a way of distinguishing who actually needs the Eltrombopag, and because I also think that even patients who respond to immunosuppression alone have better responses, higher complete response rates, I think all adults should have Eltrombopag. And that was the FDA agreed. But as I said before, in children, we ourselves do not have evidence that Eltrombopag is beneficial. So if cost constraints are operating, you can make the argument based on the paper that we are publishing in the British Journal that you can withhold Eltrombopag in that patient population. That's the best I can say at this point.
Thank you, Dr.
By the way, I want to emphasize that although our paper in press is convincing to us, as with all clinical research, we do like to see replication. Maybe we were just unlucky in the children that we chose, and I would hope that there would be, for example, a European study that would more formally examine whether Eltrombopag is beneficial. It is only one study, but it's a negative study.
Thank you. Dr. Rishi?
Yes. What is the very frequently we are seeing patients of aplastic anemia who are unable to get finances for ATG in time, and they get started on cyclosporin and danazol. And after maybe 4-5 months, when the funds for ATG come, their counts have already recovered. So, I mean, what would be the prevalence of TERT and TERK mutations? Your NEJM paper, from the initial paper which described the TERT and TERK mutation, it mentioned around 12%. But I'm sure that the number of patients who respond to ATG, who respond to cyclosporin and danazol, is far north of that 12%.
Yeah. What a good question, Rishi. So I think that 12% is high. Again, in severe aplastic anemia, we just rarely see mutations. So I think that may have been an overestimate at the beginning with those who were doing studies, especially, and this is a problem in genomics, because it's very hard to distinguish low prevalence polymorphisms from true mutations. But I think that 12% is a high estimate for patients with severe disease. I don't think your severe patients are responding because they have telomere disease. And I think the second part of your question is that I'm inferring, well, maybe telomeropathies are just more common in the Indian population. But I think there's very little evidence that that's true. Now, our GWAS will help with that, won't it? But I think that there have been some studies, if I'm recalling, that have come from good Indian centers looking at TERK and other mutations, and they are at about the same frequency as have been reported in the US, and Japan also has a similarly real but low rate. So I would be surprised if it turned out that your patients had telomere disease. They may just be responding. I mean, that may just be good therapy for them.
So what do we do with these patients? Do we give them ATG, or do we continue them on cyclosporin and danazol? Their counts have already recovered.
Yeah, I mean, if the counts are really good, in study, we're also struggling with this. I mean, we're treating our patients now with cyclosporin and Eltrombopag, and believe me, we're arguing back and forth about what happens when the patients come in and they're fully recovered. And in our protocol, we will not give them ATG. We'll reduce the cyclosporin per protocol. We'll discontinue the Eltrombopag per protocol, and we'll observe them. If the counts are stable, why put them through a hospitalization cost and certain degree of risk if they've already gotten better? We can always go back and treat with ATG afterwards. So I think it's reasonable in a patient who's had a good recovery, watch. Try to get them off the drug slowly and just watch.
Yeah, Daniel's paper mentioned around 800 milligrams of danazol dose for the telomeropathies. However, most of our patients are tolerating anywhere between 400 to 600 milligrams only.
Yeah, I think that's okay. We're doing a study comparing 200 and 400, and I think those doses are going to be too low for our patients. We see hematologic improvement, but it's not really dramatic. So I think the old number of 800 is probably accurate, again, for Western populations. It may be different elsewhere. I wouldn't go below 400. I would try to do 600.
Thank you, Rishi. Dr. Seema can think of a question. Dr. Abdullah wants to know if there is a PNH clone with aplastic marrow, how do you treat?
We don't treat differently. We rarely will see a large PNH clone. So the typical story, as you guys well know, is that there's a clone, but it's 3%, 5%, clinically not significant. It does not alter our treatment. On occasion, we will have a patient with a large clone who also has generalized bone marrow failure. And we have used eculizumab during the period of ATG administration without a problem. And the reason to do that is that immune complexes do form. We know that from very old studies that we performed. Immune complexes form. They will activate complement. And if a patient already has a susceptibility to complement-mediated lysis of their cells, we want that covered. So we've treated with both antibodies. We don't continue the eculizumab, partly because we can't afford it. But that first couple of weeks, we will have eculizumab on board.
Thank you. So we'll just take now last 3 questions. First from Dr. Seema.
Sir, I would like to know, is there any data or ongoing trial with interim results on danazol with Eltrombopag?
Not that I'm aware of.
aplastic anemia.
Not that I'm aware of.
Okay, Dr. Pankaj.
We're just studying.
Simple question. What is the right dose of cyclosporin in aplastic anemia?
Yeah, nobody knows the right dose, but I think it's, we dose by blood level. So we want between 200 and 400. I have no idea whether there's a difference between running a patient low versus running them high. And of course we monitor the creatinine. As I said, the old data suggested that you could get by with lower doses, but I'm not convinced based on the relapse data that I showed you that a low dose is enough. I think as a practical issue, I would like to see a patient get at least 6 months of full dose, 200 to 400 blood level, and then you can start to reduce as you wish. Slowly, you can do it over the course of years. Don't need to monitor, less risk to the kidney.
Another quick question, if I can ask, the role of cyclophosphamide, low-dose cyclophosphamide. Thank you.
Thank you. Sandip, you have a question? So Sandip is there or not there? Okay, so fine, sir. That brings us to an end, and I must appreciate your enthusiasm. You have been with us for 2.5 hours. You answered almost 50 questions. You gave a talk for 1 hour, and I hope your back is okay. Thank you so much.
Actually, my back feels pretty good. I was really distracted. You did me a favor.
Thank you so much, sir.
Listen, I want to say that I wish I were there. It's a pleasure to see you, Professor Agarwal, so many familiar faces, and I hope that when the epidemic is over and my back is better, I'll be able to see you in person either in the United States or India and give you all big hugs. Thank you very much for inviting me.
Thank you, sir.
Thank you so much, sir. Good day and good night to everybody.
Bye-bye all.
Bye-bye.
Bye. Good night.